Okay. Okay, let's see. Can you hear me? Okay. Okay, well, I'll try to start. I hope sound is fine and you can hear me. And to be honest, we'll try to be very interactive and not too long, okay? I promise that. Let me have closer? It's better? Like this? Okay, I'll try. Okay, yeah, we have only one speaker. Anyway, so I will try to talk to you a bit about the digital options in implantology. We're gonna mainly discuss the guides, and also we can discuss the road to the guides, including how you can get the data that is including the CT and also including the intraoral scanners. And then we can also discuss the options for intraoral scanners. Luckily, now we have an own intraoral scanner that you can see, and hopefully, if you're interested, right after the lecture or meanwhile, we can also see the scanner is right behind you because we have the electricity here. We'll also include a bit of demo with the scanner, so I'm gonna go into that as well. Let's see. So when we talk in general about evolution in digitalization, we have to really go back in time because it started long ago. In the 60s, we have the first panoramic X-rays, going up to the 70s when we had the first CT in the medical field. So that's long time ago. Now more than 50 years. Then we had the first use in 92 of the medical CT in implantology. And then we had the first introduction of the CBCT. And in 98 already, so more than 20, almost 25 years ago now, we had the first basically simulated surgery or guided surgery. That is 25 years from now. So that was the past, and now we're in the future where you can do everything yourself in any offices. First, 2004, we had the intraoperative surgical guide, but was really an old version, what we had that time. In general, when we talk about why do we want to plan at all, you have to know the basics, and I see a lot of faces from years before, so you all know the basics about implantology. We know correct implant positioning is a critical key, and also harming of hard and soft tissues is one of the main factors. Of course, experienced dentists can do that. You have experience, you're a surgeon, you do it since years, it's not a problem, and it's very easy to perform it. On the other hand, when you want to avoid complications, then the problem is with that is basically you don't have complications in major cases, but anybody can have an extra problem, an extra complication without any unplanned situation. So planning is really a critical factor when you do your daily life. Okay. Sorry, something happened here. No, I have to be here, sorry. So when we talk about implant positioning, we have the problem if you fail to plan, you can have really complications in the situations. What can happen to you is that if your implant is not exactly in the right position, you might have a nicely osseointegrated implant, but you have a complication with the prosthodontic part. That's only the minor complication, but it will influence aesthetics, obviously. Igen, az a baj, de igen, valami az a baj, nem. Jó. Yeah. Sorry, 1 minute, we're gonna try to solve the case so I can stand closer. Nekem jobb. Okay, I'll try to stand here. Is better? Okay, I hope so. So anyway, when we talk about the failing positioning, it's really a critical situation, but that's one is with planning. You can have a lot of ways how you do the planning. As I told you, we can have different ways how you prepare it, but the problem is if you don't have the right soft tissue aesthetics, if you don't have the right positioning of the implants, the prosthetic restoration will fail. This is a very old case, but as you see, the implant positioning is far not good. Another case, I love this, when it was revised to me, they tried to ask me to do the right upper bridge, but you see, I don't really understand why we need a third implant. Obviously, the plan is not really precise. I know it works and it's like the sinus lift was successful and they placed 3 implants, but I never understand why we have 3 implants where I could only restore 2 of them. Another situation, one of my favorites, patient revised for restoration. I said I just can't do the restoration. You see the fares in the plan? It's in the nerve inside, in the sinus inside, in the sinus inside, and don't even talk about the different implant types that I don't really agree with. We also have in the literature several descriptions, several complications. One of the major complications what you can have is with the submental artery when you do and by accident drill through the mandible. If it's a sublingual bleeding, you can really have complications with it. It's documented in the literature. You can see several cases, and even on the X-ray, it doesn't really look bad. But what you see with a patient, if you go under the mandible, it really can cause severe excessive bleeding. Of course, implant positioning is critical. We know the basics. I don't think we need to go into details. There's another lecture about implant positioning, so we don't need to go into that. We need 3 millimeters between implants as a minimal. We need 1.5 millimeter between an implant and the tooth. So these are basics that you might know. And also, buccally, we wish to have 1.5 to 2 millimeter of healthy bone to have enough blood supply, and the same what I told you, 1.5 to 2 millimeters of support for the bone. The problem when we have 2 implants next to each other, we need a minimal of 3 to 4 millimeters in order to avoid any type of complications because of the blood supply. So that's again another factor. And for the aesthetics, you need the vertical dimensions to be approximately 2 to 3 millimeters below the gum level in order to have the nice level of the soft tissue and have the good emergence profile. So when we go for the planning, we obviously have different options to do, and in the past we used a lot of armamentarium, and to be honest, sometimes I still use it for the planning. Everything started with analog panoramics. It's not really a present thing today. We had the panoramics, we did the planning, we did the calibration of the panoramic X-ray, and then we did counting from the calibrated panoramic how you have to do the implant, how much position, how much space you have there. That's something that you can perform. It's not so complicated, but actually not really the present today. Then we had the next step, that was the spiral tomograph, when you had a sort of 3-dimensional era where you could do a cross-section, but again, very old case just to show you what was in the past. We could plan the implant. We needed the same calibration way. That's a very old case. I wouldn't do a bone grafting like this today, but not even the flap. But what happens, you know the situation, you know where you want to put the implant, and you can build up the whole situation according to this. This is the post-op CT with the buccal bone and the soft tissue healing. What is today is, I think, in most countries it's now described, and what I know in the EU countries, but also here in the UAE, it is a must. Before placing any implant, you need to have at least 1 cone beam CT in order to evaluate the bone. So cone beam CT is really the basic. It's basically somewhat different than from the normal CT, and that's important for you to understand. We have a flat panel detector, and it's the whole X-ray is in a cone, is coming from one source, and it will give us a very nice volumetric data. It's important for you to understand how the data flow, the digital flow of this is, because the field of view is a critical factor of this. I've seen a lot of X-rays working, CBCT units, and most of them are not really used properly. You need to understand what you are interested in, how you can be getting the best resolution with the less dose of radiation for the patient. If you compare the CT, a basic panoramic, depending on the type, will be for you 6 to 20 microsieverts. A conventional CT is above 300 microsieverts, and the cone beam CT is somewhere around 20 microsieverts. the newer ones. The older ones are up to 70 microsieverts. So that's a wide range. If you use them correctly, you will have the radiation equal to a panoramic, and that's what we're looking for. Obviously, the cone beam CT is in some sorts less precise or less detailed than the conventional CTs. For example, metal artifacts or motions really kill the CT. So we have to care that the patient doesn't have too much metal on site. Also, like removable dentures, everything has to be removed to have really a good quality. As I mentioned before, the field of view is a critical thing. There are CTs on the market, they market it like big field of view, everything. Very good. If you're an oral surgeon, you are doing traumatology rehabilitation, it's good to have big field of view. As an implantologist, you don't need that. The maximum you might need is either a middle or most cases a small focused field of view. What you want to know is only where you want to do the surgery. Two aspects. One, you don't want to have extra radiation. Two, you're not a radiologist. You are not performing full scan of the patient. If you do a full CT of the patient, there are a lot of data that you don't analyze. But it's your legal responsibility that you know what's on the CT. If you do a right lower implant, but on the CT you have the full arch of the patient, and in the left upper side there is a tumor that you don't realize, and 3 years later patient gets into the hospital, they ask for the CT and it was visible there, it's your mistake, you did a failure. So it's important to focus on what you're doing. Orientation is not so easy for the CTs, and well, that's what I told you before. Basically a combination of what you can have, comparing the panoramics to the different microsieverts. To be honest, 1 day background radiation around sea level is 7 to 8 microsieverts. So basically a CT, a cone beam CT will be 2 to 3 days going to the sun here in Dubai, is the same. So not a big deal. We have now basically, that's what I told you, things that are not there you have to be aware about. So when you do a CT you have to do a full analysis of that, and most European countries we have to keep the CT to 5 to 8 years. That means it's really a big responsibility. On the other hand, we have an evidence-based guideline of usage of the CT that includes using the CT always before implantology. Just a few exemplars. If you can see if there's a lesion or it's the foramen there. So when you go for your digital workflow, the first step is to identify what type of surgery you're looking for. You can do immediate implant placement or you can do delayed implant placement. The basic question is whether you want to go guided surgery or not. If you want to do freehand surgery, then you just do one CBCT and you can do the planning. I will show you how on the CT. If you want to do guided surgery, you either do a double CT or we'll go for an intraoral scanner that I will show you later on. For the normal freehand surgery, we usually use the flap surgery. To be honest, for the guided surgery, you can use a flapless surgery, but I myself still prefer the flap surgery because of the soft tissue management. Minimally invasive flap, but I think it's better for the soft tissue. Anyhow, when you go for the flap surgery, we have an easy workflow. We start, depending on immediate or delayed implant placement, we do a CBCT prior to surgery. Usually, if it's not immediate implant placement, you have to wait 6 to 10 weeks before, after extraction, before placing the implants. I myself prefer the crestal incision, very minimal invasive, and then just cover it up with a cover screw and do the sutures. This is a short video. Some of you might have seen it from last year, but I think it's the best video to show you how the whole procedure is gone digitally. Unluckily, we don't have music from the video, but tomorrow it will be solved. So when you do the planning, it all starts with getting the right field of view. You need to see where you do the planning. All the CTs, you can modify your aspect of angulation, what you see, and which horizontal or vertical planes you're seeing. It's important that you stay parallel to the implant axis or your planned implant axis. What you need to see is the exact bone dimension that you have there. CT still has a bit of torsion, so you can have, sometimes what I see, bone is there but you don't see it. So very often it's a bit better in real life than what you see on CT. So if on the CT you see sufficient bone, usually that's enough for you. What you also need to evaluate is the part of the sinus, especially in the upper teeth or lower teeth where the mantle nerve is coming. Also what you can do, and I really prefer to do that, is when I do the planning, I already plan for the crown. I need to see what dimensions my crown can have. And one more thing, at this stage I can already decide whether I can go for a screw retained crown, can I have an angulation right for the screw retained crown, or I need to go directly for a cemented crown because of any reasons, or I need to have a restoration where I need to have angulation correction before my screw retainment. This is how we start, simply doing a crestal incision, very minimal invasive. If your anesthesia is good, you don't really have too much bleeding at all at this stage. Just opening a very minimal invasive flap just to have enough space. Not depending on the case, I prefer myself to do a flattening of the bone, sometimes even included with removing most of the cortical bone. So I use a big ball burnisher. Some implant systems have it in there. I just put an extra big ball to flatten the bone to be sure that my drills are not slipping away, because they can anytime happen to you. Then you go with a pilot drill. Usually it's sharp enough to determine any type of angulation, any type of what you wish to have. This is what we call mental navigation. You watch the CT, you have some ideas, you have some pictures, but you do the whole sequence freehand. Then the normal sequence follows, depending on the system. Here with SGS, you have parallel drills, so you go and do the bone housing preparation one by one, starting up with a 2.0 diameter, going up basically a few sizes before the final diameter of the implant. To be honest, the system allows us to skip a few drills because you don't need to have all these 2, 2.5, 2.7, 3, 3.2 and go on. I myself don't like to skip the steps. I think it's easier. It doesn't take too much time and it's easier not to skip the steps. So I just go and follow up all the drills what we have. Depending on the situation, whether we have hard bone or soft bone, the protocol will be different. This is softer bone, this is maxilla, so with the 3.2 we only do a cortical drilling, because for the 3.75 implant that's more than enough. As you see, placing the implant is quite easy. We all know it has a very aggressive thread, so it's basically self-tapping, so I don't need to do too much for preparation. Comparing, I see a lot of implants here in the market now. We have different types. We have implants with small threads and we have implants with big threads. It is a different way how to do that. It's like driving a car, automatic or gear drive, total different way. You cannot use the same protocol for these types of implants as you were using for, let's say, a camlog implants. So it's always important to consider this aspect when you do that. The surface treatment we had earlier, last year and the year before, lectures about that. It's a double combined surface treatment including hydroxyapatite that is really unique and is ensuring us very quick bone healing and also integration. As I told you, in this case we did a crestal incision. We're going to place a cover screw and we're just going to do a very small suturing. Actually today I would suture it one thinner and do it for a, let's say, 5.0 suturing. Having with all pros and cons, I prefer to have even thinner sutures today. Usually such a case requires 1 or 2 sutures, nothing extra, and you can remove the sutures in these cases even maybe after let's say 2-3 days. So you don't need to leave it for weeks. Of course, if it's a bone augmentation case or something more complex, you have to leave it for a longer term, but for these basic cases you don't need that. After healing, I prefer in these cases to wait for the 3 months of healing. Once we have the healing, after the 3 months, you expose the implant, or if you had enough primary stability, you can do temporization right on. If not, you expose the implant and then go for the prosthetic rehabilitation. This is after 3 months. soft tissue formation, and then a screw retain crown. Simple thing, I don't like to overcomplicate the things. For single tooth, a nice, easy screw retain crown is the best. Anytime you can remove, if patient loses other tooth, you can transform it to be a bridge. So you have several options how you can do that. So going back to the question, what if I want to have guided surgery? And that's where the digital workflow comes into the difference. You have to understand what data we need for that. We have different types of surgical guides. Originally, we had three main types: bone supported, mucosa supported, and tooth supported. We divided now more to four types, where the bone supported is really the past. We used to have that. We did a CT, and then we had a big exposure with a big flap, and you put the guide directly onto the bone. On one hand, it's good because it goes directly on the bone, so you don't have the soft tissue as influencing factor. On the other hand, we know from the CT to the software to the printing, you have certain data loss. It always makes a bit of uncertainty. So studies showed, though it looks to be theoretically more precise, in real life it's never more precise than having the soft tissue restored guide. Tooth supported is one of the best what you can have. It's most reliable. All the studies are showing, I will show you also on data, much more precise. What you have tooth right and left, both sides, where you want to have your implant site, and then you place the implant. The tooth and gum supported is a combination. That's usually for lateral situations when you have teeth in the mesial side, but distally there are no teeth. So like this case, this side you have one molar tooth here and the premolars. This means this is a tooth supported guide. But that side, as you distally, you have no more any anchorage. That's basically a skeletal anchorage. You only have the soft tissue. That's a tooth gum supported combination. There we will have more deviation for your plan than what you have here, obviously. And then we have the gum supported things. Today what we know, it works, it's nice, but gum supported always will be a compromise. You have to expect much more deviation with any of the guides, any type and any ways of drills are to do, especially because the soft tissue, you can't even do a noise scanning on the soft tissue. Usually you need to have an impression with all these drawbacks with the silicone and these dimensional changes, and also when you put on the guide, soft tissue has its resilience. It will be influenced how much you push, whether you push stronger or your nurse pushes stronger on the other side, or when you do the skeletal anchorage, when you do the pins, is it really on the right position or not? So it will really influence it. So I really warn everybody, when you use the full guide, be aware, here we have much more torsion than what you expect. So going back to the digital workflow, how can I get my data in? Depends on the guide system, but basically you need a CBCT from the patient, that's not a question. And then you have options. You can do a dual CT, so you can use your same CT machine to do a CT scan from an impression or a radiological stand. You can have a simple CT where you just do one CT and then you use either an intraoral scanner that I will show you now or an extraoral scanner, so you take an impression and you send it to the lab and your technician will do the scanning. All works. What you need to do is just to merge the data. Do a CT. In the dual CT, usually we use it when you have no teeth because you don't have reference. What you need to do when you do a CT, you have to have something in the mouth of the patient where you have markings. It can be a denture of the patient. It can be, let's say, an individual tray where I put myself, I drill in myself, gutta perha, simple root canal filling GP material. Or what you can do, you can buy it on the market, or you can even do it yourself. You make a plastic tray where you put in gutta perha points. The point is what you do, you take a CT with a patient having that appliance in the mouth, and then you take another CT only from the appliance. And what happens, you extract from A, B. This means I know what you don't see. I don't see the soft tissue on the CT. I need to know. When I take the denture or take the impression, if I extract this data from that data, the rest is my soft tissue. Simple. So that's how it goes. The only critical thing, you need to have the radiological points. Usually they say you have to have 3 points, but I know most softwares need 6 to 7 points to be precise. So always I'm going for 8 or 10 points usually. The simple CT is the future. When you have teeth, it's much more easier. You either take a CT from the patient and then you take an impression and scan it, or you make an intraoral scan, quite easy, make a very nice scan, works nicely. There's a critique with all these techniques. We need to have, and also you can do impression and extraoral scan. We need to have reference points. As I don't have the GP reference points, you need to have the teeth as reference points. So my patient needs, for this case, 6 or 8 sound teeth. Sound means no metal. I can have composite filling, no problem. I can have ceramic crown or inlay, not zirconium, but pressed ceramic. So no metal artifacts, nothing that will cause distortion in the CT. That's where I reflect back to what I told you with the CBCT and the medical CT. The medical CT doesn't care about your metal artifacts. Your CBCT is dead where you have an amalgam filling. So that's a factor when you do it. If you want to do this technique, you either remove the amalgam fillings of the patient, or you consider that you have a limitation, you need certain number of healthy teeth. Because what you need to do, and that depends on the software, you need to put data A and data B together. Data A is your CBCT, that will be your DICOM, and the second data is either with a dual, the second CBCT, or with a simple one, you just use basically intraoral scanner data, that's STL, but use it. And then you merge the two data. Once you have it, then you can have it, have the guide itself. We had an own research where we compared the different ways of implant planning. We had the 4 ways was freehand. First I showed you, see the CT, figure out what you want to do the implant by the mental navigation. Or we do a pilot, that means we do a planning, we have a guide, but that's only for the 2mm drill, and everything else I do by freehand. Option number 3, I have a guide, I do the bony housing until approximately the diameter of the implant. Lányok, zene jön ebből, valahogy nem kéne neki. Ki kéne kapcsolni, valaki valamit csinált. Valamit csináltatok és jön a zene. Okay, sorry. Nem jó. Most... Igen, de nem zene jön belőle, meg most gerjed. Tekerjétek vissza. Sorry guys, okay. A levelt vegyétek le, tehát föltekerték a leveljét a mikrofonnak. Okay. Better now? Okay, sorry guys, I don't know what happened. It's always difficult to make the lectures, you know, this is live, very live. Anyway, so a monitort rákapcsolták az egészet, tehát elég ez a hang. Rákapcsolták a monitort, vagy mit csináltak? Nem kell. Okay. Now it's working. Sorry guys. So group number 3 was where we had the guide. We do the drilling until the housing of the implant, but the implant itself you place freehand. Especially with these aggressive self-tapping implants, you still can have some torsion. Or group number 4 is actually when you place the implant through the guide, so the implant placement itself is guided. One more factor that influences success. What we had, after the implant placement, we had more than 220 implants. After the implant placement, we did the superimposition, we had the preoperative and postoperative CT, and we compared how much deviation we have, original and the final. So our plan and what happened. Results showed us that basically angular deviation, so how I deviate from my angle, is really different. From the freehand, you have a 7 degrees of angular deviation. What shows us more is the apical deviation. This means my apex of the implant, how far is it away from basically what I planned. With the freehand, I'm 2.5 millimeters in average away. So if you think at that case, if you plan something with a freehand CT, you can expect to be 2 to 3 millimeters away when you plan. So your distance from nerves, sinus, everything should be really far. With the guide, we were in the average down to 1.59. It's much more precise, but still more than 1 millimeter. So that's why most systems, when you do a planning, they have a security line around 1 millimeter, 1.5 millimeter of line. So then going back to a case, guided surgery, we start with doing the CT. Either you do a double CT or you do the intraoral scanning, and then you do the performance. I just want to note why I like to place healing abutment. If you just place a cover screw and you did a flapless surgery, you can end up with having the sort of bone loss there. So I really suggest to have all the time cover screw and suturing, or healing abutment, so you have nice soft tissue forming around the implant. So another case, we have a tooth, failing root canal filling, failing tooth. You remove the tooth, you wait the healing time. And then you prepare for the implant. That's the guide going in.
Még mindig egyébként van. Nem, még mindig ugyanaz. Olyan lassan van. Bekapcsoltak valami hangot. I have echo. I didn't have echo. Now it's echo.
Hello. Just speak it.
Okay, so this time we're going for a flapless approach. We just remove the soft tissue. I'm gonna not do the flap. I prefer myself doing the flap. For me it's easier because I like to see the bone. But for the patient, it's very comfortable not to have sutures. They love not to have sutures, I know that. It's an aspect what you prefer. It's well, the fight between you and your patients, that can they bear for, that's why I prefer placing the sutures and remove them 3 to 4 days after. So it's not too long, they can bear that. In this system, we had these spoons to make them narrow, so we end up with thinner drills, and then we do the extension one by one, having bigger and bigger drills until the end, until we have the housing. In this case, it's 2.5, then going with a 3mm drill. And on the end, we just have the last drill for tapping a bit. And then you just do the implant placement. So you do the core drilling of the implant, only the last drill is freehand, depending, same case as before I told you, we go on the sequence, we're gonna have all the drills until one drill before the implant. So for this 3.75, I'm gonna place a 3.2 drill and then just go with the implant straight on. For the maxilla, it's enough. For the mandible, I would do a bit more pre-drilling to be sure that I don't get stuck in the bone in the middle if it's really hard. I tell to you every year who's here earlier is that we need to remove the carrier before putting high torque on the implant. So when you start implantation, you go till a wide, then you remove the carrier and go directly into the implant with the instruments. That's where you achieve high torque. So that's how you can go for the 60, 70 Newton centimeters as much you like. I prefer to finish with a ratchet, hand ratchet, not with a machine. There's no extra point on that. I just prefer myself to feel in the end how that's really tight in the bone. As you see, we have quite enough high bone, high primary stability. So in this case, I could even consider putting a temporary crown. The patient was not willing to get that, so it's not really a point, but that's an option to have that. There is a control to be controlled where you are you really on the right position, what you planned? And then you just do as I told you, not a cover screw. I'm going to go for a healing abutment, so the gum healing in the 3 months will be exactly nice. The negative is if patient is not cleaning properly, I usually like to check it after a few weeks if it's really shiny. I tell the patient, like, you see this is a metal. If it's shining, you're doing good. If it's not shining, you're doing something wrong. So that helps very nicely. So this is the healing abutment, and that's just on the gum level. It's really nicely being healed. And after 3 months, we just remove the healing abutment. This is a different way of impression. And then we go for the final crown. Again, simple screw retain crown, nothing extra. So for the surgery itself, we have the guided tray that is basically covering most of the systems. It's in Blue Sky, it's in the SGS different systems, so you can really use that tray for any of the systems that is included. If you're interested, we have a list of systems where what you can use for guidance. The tray is very simple. You can either have soft tissue punches if you want to go flapless, or you can do the crestal incision. Then you have the basically the bone mill, what is the zero drill, where you have to flatten the bone instead of doing the ball burnisher, what I told you, it just flattens the bone. And then we have the different drills. You start up with flattening the bone, then you have the initial drill just to punch where you start, and then the system will go directly into the right length what you need. So in the guided system you will see implant lengths, and you will do increasing of the drills until the length you want. So, and then the insertion tool for the end, as I told you, the implant insertion is through the guide. So this is how it goes. Like we start like here. You have punch, and then you go one by one. For example, for this length, just go until the diameter you want, depending on which diameter, 3.7, 4.2, what is needed. You see, there are the lengths, so 13, 11.5, 10, 8, and 6. So depends always in the case what you want. Insertion tools, according, if you know the system, according to the platform, whether you have the conical platform, you have the regular hexagon, the conical platform, or the narrow implants. So always take care that you use the right tool for that. This is another guide. I like to work with different systems. This is a SMOP guide. This is a fully guided software, so we're going to go full guidance. We have the whole system included. So it's very simple. You just get for the case selection. I will run through a bit. You have the three-dimensional visualization of the implant. Critical is that you have all the threads and everything for the implant, so you can exactly plan your implant position. But I like to, that's what I told you with the orange line, to warn you about the distortion. We had 1.5 millimeter in average, so in all softwares, be aware that you need to have a security distance. You can have different aspects. I like to go horizontal and vertical as well to see if my plan is not hitting any of the anatomical structures. This is a bit more complex case, if you see, because we have a curved tooth there, and we were afraid we're going to hit the apex, so we really had to care about which angulation we put the implant. This is how the planning goes. It's quite simple and easy. You go in, you select the case. Okay, so we have the three-dimensional plan. As I told you, we need to select how we do that. I'm going to skip a bit. In this software, you need to select exactly how are the positions, which teeth you want to prepare. In this software, you do the superimposition yourself, the merging. The other software I showed you before, you don't do it. They do it for yourself. It's a cloud-based system. You upload and you upload the two data, STL and DICOM, and you get back the merge thing. But it's simple. 1, 2, 3 dots here, and the same 3 dots on the STL, and then the computer does it. So not so complicated. But it's a computer thing. So as a dentist, you have to learn deal with the computer. That's something most people, they're out of their comfort zone with that. The good thing with this, you can plan also the prosthetic part, so you can go see the crown, see the prosthetic angulation of the crown. If you have 3D printing, you can also print a three-dimensional plan, and helps you with changing the angulation, with seeing if you can do screw retained or cemented, and also even ordering the abutment. We'll go for the end. And this is, and also what I don't like, some of the systems, they require you to plan the guide yourself. So you actually plan the guide. It's also an automated software, but you need to work with that. It's like digital digital working. So it's not really the easiest thing for us for dentists.
Figyelj, sétálj már át egy pillanatra a másik oldalra, hogy milyen a hang, jó? Csak meg akarom érni.
Okay, they told me to come here. I don't know it's better, but I don't know if it goes from there. We'll see. And this is the surgery itself. Same situation, similar tooth missing. You just make a crestoral incision.
Jó, csak így nem tudok belenyúlni. Jó, csak így nem tudok belenyúlni, ha változtatni akarok, de mindegy. Jó.
You do a crestoral incision, you just open the flap, you have a small flap. This is the guide, this is a total different way. I like this guide because it gives you more visibility and more space for the cooling liquid. So your irrigation is better reaching the target. So I would say less heating, less heat production. Yeah. Yeah. And then this is the guide system itself, the drilling you do with a bone mill, and then you go one by one with the different drills according to the lengths you wish. I like to have a control. When I first drill, I remove the guide and have a look. I never trust blind. You know, digital workflow. It's good, but it's not warning you if to place the implant here instead of there. There's no warning. Theoretically it's good, but what if? So I always have a visual control. I never trust just the guide. That's why I prefer to make a small flap, because you make a flap, you have a look. It's there, it's okay. So just one more extra control on the whole situation. Sorry? No, this one is no spoon. For this system is no spoon. Actually, even the extender is not there. I just made it with the extender because so you can see, otherwise you don't see because of my handpiece. So it's even long, it's even shorter for normal cases. And then you extend, as we said, one by one according to the implant length. So you just go until you need the right diameter, and you always go until stop. So basically, this is what my kids could do. They just push it until it goes. No thinking, no dentistry in there. If the plan is good, it becomes really less dentistry now. 3.7, 11.5 drill. Just go in, full length until it stops. Again, I like to have the visual control. Am I right? Didn't I break the bone? Didn't it deviate or anything? And then it comes through the guide. So this is a P5D. I will put it through the guide itself. In the beginning, it's basically has a bit of free movement, and then once you have the initial, you go with a ratchet, and then you can have the guided placement. So there's no other chance to have any torsion or any distortion from this, even with this aggressive implant types. The only thing what I've seen, if I really put it onto hard bone, I fix it. If you do several implants, everything is good, and in the end, it's difficult to remove your guide because everything is so tight. You anchor the whole thing. So I better, when I put one implant, I remove the guide, have a look, and then I put the other. I don't leave it in there like that because it's really hard. It's hard bone, hard implant, everything. And then you're there. After that, the same way, cover screw, suturing. Simple thing, no extra complications. Okay, there's with the cover screw. This is already 4.0 sutures, a bit thinner, still going up for less thickness always. Yeah. And then we go for the other question what I already raised is how you get the STL data, because you can do the CT as we discussed, but you can also get the STL data. It's good for the guides, but also very good for the restoration prosthetic part. Now more and more labs have the digital workflow. So what you need to do from your side is to enter yourself. You don't need to send any more impressions. You can, but you don't need to. You can do the digital impression. There is a limitation. What I think is a full arch restoration, the same what I told you with the full arch implants with having no teeth, that accuracy becomes less and less precise. Yeah, they don't really suggest. They say they safe. I haven't seen a study showing independently they are safe. You know, with a lot of practice, with exactly fitting staff and personnel and practice, you may be as good as any dentist is with an open tray impression. That's my problem. So it is the future, but for that you need to train a dentist to use that as long as he's been trained for his regular impression. How many years you're doing impressions?
20 years.
Okay, call me in 20 years. Are you good in the same way with the digitals? But now training half a year will be never that good. Okay, maybe not 20, but in 5 to 10 years. So anyway, actually in the literature what you see is that it's reliable. Even with most implants, with tilted implants or everything. But full arch, tilted implants is the limit for now. So I would say basically operator experience, implant angulation, and connections and defects are factors that might influence it. Different studies show different outcomes. So if you see one study, it shows nicely. Other study will show you in a full arch there's a lot of torsion. So I would say there's a limitation. For me, it's now for like, let's say, half arch, one side.
So you never did a full arch?
No, I don't do full arch with that. I do, the maximum I prefer is one quadrant with digital. Because studies show in a quadrant you don't have that much torsion. In a full arch, you have this special lot of torsion. So that's already there. The scanner, what we're talking about now, what I can show you here is basically an option in the market now. We have different scanners. I can see now hundreds of scanners being produced. I think what is important is some of the features of the scanner. It's not the branding, it's more about the features. This is right behind you, so we're gonna have a try if you're interested. Basically, it's a chromo scan, and also it's an intraoral camera inside. This means basically it also includes colors, so you can have basically an intraoral three-dimensional color picture of the case, and you can do photos meanwhile. Today I think it's very good for documentations, because if you have any issues, any cases, legal cases, they always ask you for photos. So you can really collect these photos. I made a short video how that goes. Yeah, it has an anti-fog module, but that I think today most of these have it because patients exhale and that really disturbs us. So this is really a live timing. I didn't modify anything. I just switch on. It takes a bit time until it finds the first situation. You go to the patient. You need to find the first stage, and then it really quickly goes. We don't have sound from that. It's like the snow cracking sound. Some have these, I don't know, weird sound. I prefer the sound of this one more, you will hear soon. And it's quite good. All scanners are good in scanning. The question when they lose the situation, how quick they find themselves. I think this one is very quick. You see it lost and it finds itself in like a few seconds. So it's always a critique when you change your movement, how quickly it finds back. That's the issue. You don't want to have too big data again. You just need enough data so you can do the scanning. This is a scanning of the prosthetic part of the implant. So we have the implant scan body in there. Your dental technician can download it from the SGS website, and then they can use the matching software module for that. So it's quite simple and easy. To summarize, depends on the software of your dental technician. Some softwares will ask you to do a double scanning, you're right. First do it without the iOS, without the scan body inside, just the implant purely, and then you do it with a scan body. depends on the software. Most softwares will require double scan, you're right about that. So in general, what we have today is it's an option to go away from the dual method and with the CBCT or the impression of the patient, and you can directly go for the scanning. So I think I will stop my presentation here because we reviewed the whole options what we have with guides and with the scanners, and we'll go for the ones who's interested to see the scanner and scan. I wouldn't say your teeth, but at least the mandible or something here, because I don't want to talk about the scanner. You need to see yourself. It's not like I can explain you how nice it is. It's like explaining about food. I can tell you how much it tastes. If you don't taste it, it's not going to feel it, okay? So thank you very much for your attention. If you have questions, happy to answer.
Let's see the scanner.